let's give a floor to Michael Burdukov. He is a senior researcher of the Russian Cancer Center. And we're making bridges to pathomorphology. Topic of this presentation: methods of obtaining material for morphological studies in pancreatic biliary disorders.
Dear colleagues, dear guests, dear panel members, thank you very much for passing the microphone again to me. It is a great pleasure for me to be one of the speakers at this workshop. I have the following task: to talk on a very narrow and very special topic, which I would like to demonstrate on the pancreatic, taking as example pancreatic tumors. And I'm going to talk about methods of sampling material for pathomorphological examination in the pathology of pancreatic biliary area. So, if we speak about pancreatic tumors, according to the Eurocare study, this way or another, despite all our efforts, the median survival time accounts for only from 4 to 6 months. The data that I analyzed means that if the detection rate is about 67 patients per 100,000, then the survival rate within 1 year, so only 7 patients will survive 12 months. If you rate survival by years, you can take such endpoints as survival within 1 year, 3 and 5 years time. So the survived 16% within 1 year, 5.53 and 4.1 survived over 5 years. That means that this disease is quite aggressive, and despite all our contemporary efforts, it has very poor forecast. Most probably we still can do something for at least these 16 patients who can survive up to 1 year, so that means longer than from 4 to 6 months. Epidemiology for 2011-2012 from Professor Davidov. It's very important to do the pathological verification of the tumor. About 46–48% in the preoperative verification was conducted. But this is very concentrated data that comes from the oncology settings and other establishments which are subsidiaries to it or affiliated to it. I have certain information that shows that not every setting provides morphological verification of diagnosis, and if you travel away from St. Petersburg and Moscow, I mean major cities, even if they perform certain surgery in the pancreas, it is usually done without morphological verification or without any detailed examination of patients. Or it is the surgery is not performed and these patients are just followed up. I have a good example from some remote area of Russia. A patient is transported to me, to my hospital. He was followed up as AIP patient, and then after FNA, we diagnosed him with cancer. But they lost about a year. If we speak about a screening and about cancer detection in screening procedures, it is impossible because it is quite aggressive disease. But on the other hand, this 2.3% show that we do not have any screening in place at the moment. simply because it is not organized. Second, because we don't know how to organize it. And third, because we don't know how to adjust our experience to the biology of the tumor, because if the tumor is already there, then within 1 year it can just virtually kill the patient. And at the end of the lecture, ask me about how the tumor develops and when and how to demonstrate it, because it is not in the frameworks of this talk. The first and the second stage of this disease are optimal for surgical intervention, and it is detected in less than 13%. That means that statistics shows very poor detection rate. And stage 4 is about 60 patients. So that means that fourth stage means that all our efforts that we invest, they are not successful because the patient already has remote metastasis, and we cannot speak about any surgical intervention in this cohort of patients. This is just compassionate or palliative treatment. This palliative treatment should be, again, grounded by the morphological verification, because you cannot do anything else apart from the chemotherapy, plus our just palliative or compassionate treatment. Unknown or undetected stage occurs at about 7%, and mortality within first year is accounts for 68% of the cases if compared to European data. Then it's 100 minus 68 means 32. That means we have quite successful, quite good data. So, you know the diagnostic modalities. This is ultrasound, CT. Ideally, if it is performed with IV contrasting, it can be. We can do also MRI with its very specific tasks. And it is mainly focused not for the primary lesion, but the metastatic lesion in the liver. This method is better than CT, and it allows us to see the structures of the liver much better than ERCP, which has very narrow application, draining of the bile ducts and achieving certain information on the bile ducts in EUS and CA19-9. This is something, some marker that we are very well informed about, but not very many people know that CA242 is the oncomarker, which is more specific. Its specificity is 5-fold as high as CA19-9. So if CA19-9 elevates at stage 3 to 4, then CA242 can be elevated at the first or second stage. And also cancer embryonal antigen is something that we can consider. What I would like to focus on, first of all, that we have non-invasive method of diagnostics such as PET, CT, and the EUS. Their sensitivity can be compared. It is quite good. It ranges between 80 and 90%. But if we speak about specificity, then the specificity of EUS is higher than PET and PET-CT. These are imaging modalities. So we can say that, yes, we have seen something, then we can compare this to the post-operative statistics, but we still need pathological verification, and this is EUS FNA. Not in all the settings, but in the best ones. We have statistical study, and they show that the sensitivity reaches of EUS FNA reaches 95%. This slide also shows the following statistics. The negative predictive value is about 85, and PV is about 85%. This tells us about the fact that if we do not have any pathological verification, it doesn't mean that the diagnosis is not there. This is something that that is worth struggling for. Now, application or applied value. KRAS mutation is quite a good analysis, but we need it only for deep diagnostics. But there is no clinical application of this oncomarker, simply because we do not have any target chemotherapy for patients with mutation in KRAS. So generally speaking, this is a diagnostic modality. And the mucin expression pattern is typical of the mucin-producing type of tumors. So how can we prove what we actually see? By means of imaging modality. It's not just some mass, but its malignant nature. There is only morphological verification that can help us. The main modalities are here. First of all, it's surgery. Second, it's percutaneous methods like CT-guided or EUS-guided biopsies or punctures. And also FNA EUS. This is intraluminal method. Surgery is a wonderful method which is used everywhere. So if we conduct this surgical intervention and we take some sample, then we either will do a tumor fragmentation and send a sample for morphology, or we will perform an FNA. And in 100% of the cases, we shall receive a result. However, we increase operating time to do everything correctly. On the other hand, this is the Russian reality, and we should remember about it. If we take a patient to surgery, and if we do some intraoperation specimen sampling, it tells us about the following: that the patient is under-examined before in the preoperative period, and I suppose that such cases should be avoided. It tells us about insufficient examination. We don't have morphological verification. We don't know whether it is cancer or not. We don't know the volume of surgery. If we do this primary lesion biopsy in order to have morphological verification, then we speak about an ideal patient for surgery. No ascites and no liver metastasis, so we can afford it. But if we look slightly above and look at the statistics, so in fact it's not realistic, and the intraoperative sampling and morphological verification, these are patients who cannot be sent for radical surgery. Such explorative laparoscopy should not be done. There are MIS methods, and which allows us both palliative treatment, and surgery is something very far-fetched for these patients. Further on, precutaneously guided techniques, drainage methods, they can be very sensitive in terms of detecting tumor cells, which account for, the sensitivity accounts for approximately 80%. This is something that is done in the literature sources, and it's quoted. We have a risk of tumor cell contamination via the puncture route. If we speak about curable patients, potentially curable patients, or incurable with stage 4, then morphological verification is needed in order to adjust chemotherapy. But in the lucky ones who are at stage 1 or 2, in patients where we can perform radical surgery, this risk should be excluded. The patient should not undergo such high risk. If we see stage 1 or 2, if we are lucky and we can do radical surgery, we should actually be ensured not to contaminate the tissue. And probably you were had an experience with FNA. This is transcutaneous investigation. So from the skin to the lesion, we have about 12 centimeters. And the tumor itself is about 2-4 centimeters. The needle manipulation is quite restricted. So at the moment in congresses, we look into different methods of FNA, EUS, such as the FAN technology, when we sample material from different tumors locations. These are absolutely different methods that allow us to improve the sampling techniques. By means of transcutaneous ultrasound, we cannot do it like the FAN sampling technique, because the angle, or by changing the direction by 2 millimeters manually, we change completely the ultrasound window, and the needle will be lost from the observation. So CT guided FNA, also very accurate technique. But what do we have? We have two situations when we just punch the needle and then take it out, then punch it again. So it's a sort of discrete attitude, or discrete treatment of the tumor, which definitely distorts the accuracy. On the other hand, if we're not afraid of anything, we can switch on the CT and we can do the FNA, take the aspirate. But we know that time under the CT means very high radiation exposure. And I suppose that such specialists in a year will probably retire. Because the exposure is too high. So this method should be considered once again. Then EUS FNA, the lowest sensitivity is 85%. This comes from Paul Fawkins, 1999. Specificity is quite high, 98%. The negative predictive value is about 55%. That means that if we perform FNA and we have no result, that means that we cannot say that the tumor is not there. I don't know where the source is, but from the oncology viewpoint, we consider that FNA should be performed at least 3 times, and only then we can say that, yes, there is no oncology, but not release the patient or discharge the patient, but arrange an appointment with this patient in half a year for control examination. So this is something that we should remember. If we don't have it, that doesn't mean that the oncology is not there. Now, these are multi-centered randomized trial results. The method has been performed since 1995, so we have accumulated vast experience, and with time, gradually, we also improve the efficiency of the method. Further on, we should say that FNA can be also used not only in the pancreatic cancer, but also in neuroendocrine type of tumors. The only thing that we should say here is that in our country, we do not have any additional imaging methods of neuroendocrine tumors. We have endosonography, but we don't have contrast examination modalities. Those who are inside the business probably come across the situation that neuroendocrine tumor at the background of non-changed parenchymal is very difficult to detect. If you get an image, we can, of course, visualize things, but it's difficult to get an image. So what else do we pay attention to? That the applicability of this method in cystic lesions. It is not even 85%, but it can vary from 21%, and 21% is very low. So if you work with this type of tumors, you know very well that these tumors have different biology, and if it is a mucinous or cystic neoplasms, if there is only stroma, if it is ovarian type, so to say, like a ovarian stroma, we should take the sample from the stroma. It's only 1-2 millimeters. It's just the cystic wall. And you should know a lot, really, in order to have correct diagnosis, which is not always possible. But the sensitivity is quite good, specificity is quite good. It's about 100%. If we speak about the analysis of markers, it's an additional method and it can help us. So CEA, it's a very good deep diagnosis. If for cystic adenoma, we'd have less than 5 ng per liter, but for mucinous cystic neoplasms, with the reference value and with the elevation more than 400 ng per liter, we can say that it's not a usual cyst, but a mucinous neoplasm. So the sensitivity is quite good. Then CA19-9, this is the marker that definitely should be assessed if you have suspicion of mucinous neoplasm. If it is over 50,000 units per milliliter, then with a sensitivity of 15 and specificity of 81%, you can perform deep diagnosis between just the usual cyst and mucinous cyst. With the sensitivity of 86 and specificity 85%, it can also help us to differ cyst adenocarcinoma from cystic lesions and amylase levels. The higher the level of amylase, the more we think that it's a pseudocyst, but not some cystic malformation where amylase elevation is not that high and it's not specific. Complications. Of course, we have overall complication statistics. These major complications occur in up to 2.5%, but there are certain very fine things. If the complication for solid lesions is at a minimum, it's below 1%, but for cystic neoplasms, it reaches 14%. If it is so, then we should definitely think what kind of method to use. What kind of complications can occur? It's purification. So it should be either complex approach or FNA. If you cannot do without FNA, if, for instance, Albert said if this is not a woman with a very small tumor, then we should not resort to this method because simply it is associated with risk of complications. The main risks are pancreatitis and bleeding, and also the risk of contaminating along the route. So we should be very selective, especially when we speak about cystic neoplasms. Further on, invasive methods of imaging the strictures of pancreabiliary zone, EUS, ERCP, and PTC. For EUS, it can be useful for diagnosis and staging of malignant biliary strictures. If EUS is performed with the suspicion of malignancy or malignant stricture, then it can be verified in 88% of cases. What can be a prompt? If the wall thickness is more than 3 mm, this is exactly the criteria that tells us that most probably this thickening is of malignant character. Further on, ERCP or any other direct contrasting, either retrograde or antegrade way, it doesn't carry any logical significance because characterizing the structure as malignant has very low specificity by this method. It's just 66% and the specificity is about 51. It's just an imaging method. And we have other ones which are more successful, such as intraductal brush cytology or biopsy, which is not a golden standard as well, and its sensitivity counts for only 42%, but the specificity is 98. This is good. Then, the method that I have never seen in my life, and I've never heard about it in Russia. It's the Intraductal Trans mucosal FNA in order to get this sample. This is something I saw brush biopsy under EUS, but the brush, and it accounts for 56% in terms of sensitivity. The next method, which is intraductal forceps biopsies, again, it is done under direct contrasting of the bile ducts, and we do a particular biopsy from a particular spot. This is good already with the highest sensitivity and specificity. What other ways and modalities do we have in order to expand our knowledge about the character of a tumor? It's intraductal ultrasonography, but again, telling exactly whether it is sclerotic cholangitis and or something else, it's very difficult. And another one is cholangioscopy. Sometimes it can be informative, but we do not always, we cannot always tell for sure that it's a tumor that we see. Thus, the clinical utility of EUS in the biliary structures. By means of sonography, quite naturally, we can identify and visualize the structures in 98% of the cases. Yes, we can see it. But when we perform EUS FNA with some positive result, as I've already told you, it's 58% of the cases. But if we add cholangioscopy to this method, then our diagnostic value is improved, and we can do deep diagnostics and do the biopsy. If we use a combination of all these methods, I mean imaging and biopsies, we can reach the efficiency of up to 88%. If we use endosonography and cholangioscopy, then actually we can optimize our diagnostic value up to 94%. And in conclusion, I would like to say that all the visual opportunities that we have in our hands today are insufficient for correct diagnostics. We can see something, but we very frequently do not understand what we see. And the most important modality is getting morphology. This is exactly the starting point when just a patient becomes an oncology patient. We continue working with this patient. There are a great number of ways of obtaining a morphology sample, and each of these ways is one of a number. So we should remember always that we have other ways of achieving aspirate in stock, and using a combination of these methods and modalities may definitely increase the success, but at the same time we should count money, because it also increases the cost of treatment. Your experience, your knowledge will probably give you a chance to verify your diagnosis in a shorter time and with less expenditure. Thank you. Thank you very much for beautiful lecture, dear colleagues. Any questions? We have a chance for questions now. Please put up your hands and we shall immediately give you a microphone to speak in. I have the following question. You are saying FNA. What do you mean by FNA? Because it could be like, it can be cytology and needle biopsy. So it's very important actually for morphological diagnosis. Is it cytology or is it histology that can be assessed? Thank you very much. That's a good question. And probably I should have started by telling you about the method as such. I am talking about fine needle puncture, and I mean it's cumulative data, by the way. There are methods when we use aspiration, fine needle aspiration, when we just have a vacuum which is switched to the needle, and thus we get an aspirate. Thus we have both histology and cytology sample. So the data that I have shown you, this is the data from a statistical analysis when the golden standard was compared to intraoperative specimens, and mainly I was talking about cytology. If we speak about very specific type of tumors like neuroendocrine tumors or gastrointestinal stromal tumors, quite naturally we should be speaking about histology then. But the statistical data that I have been operating with, which are well quoted, this statistical significant like trocate biopsy from the same producer and using aspiration biopsy with histology or cytology further on, they give similar opportunity. Thank you very much. That's been very interesting. But nonetheless, for us internalists, GI specialists, what recommendations would you give on choosing the diagnostic algorithm, taking into account not only clinical aspects and targets, but also the very last conclusion you've made, like the cost, the financial matters, because we should have our both feet on the ground, and definitely we should understand that not all the methods that you have mentioned are economically reasonable. I suppose that this problem should not be a headache of the GI internalists or therapists. I think that it's a system that should carry the responsibility, and those people who are reformers to our health system, they should deal with it. This is quite serious issue, and the only thing to do is to detect. Early detection means annual screenings. On the other hand, we understand that performing screening among all the population is not realistic. So that is why we need to have some high-risk groups, like people with chronic pancreatitis, oncology, or familial history of pancreatic tumors, and third and most realistic risk group is, once again, those people who count their money, who understand that if they get tested and examined, if the disease is detected at earlier stage, then patients will be cured, and lots of money will definitely be economized for more advanced treatment of more advanced stages. And the person, for instance, will not lose money that he can make while still working and being in business, for instance. What we definitely can propose, and it will be less costly than all the rest, is taking part in the establishment of the so-called social advertising. Like we have such thing as belching and heartburn. If, for instance, but not many patients are informed about the origins of it. So first of all, we should give the weapon of knowledge to our patients. Okay, we have genetic determination, we have certain predictors of pathology development. What do we administer? What would you administer? What algorithm, what sequence would you propose, from the simplest to the most complicated? Or would you take sensitivity and specificity as main indicators for the diagnostic modality? Okay, let's step aside from economic matters. Epidemiology says that the linear convex endoscopes at the moment are used all over the world, and they are rate first. But nonetheless, we still have radial echo endoscopes. They can be used for the early cancer, pancreatic cancer screenings. I wouldn't say that they're better, but nonetheless, certain European centers and Japanese centers consider that the endoscopic ultrasound is exactly the screening modality that we can propose. Why EUS? Because neither CT nor MRI, nor other diagnostic modalities or imaging techniques can detect, or statistically significantly worse, detect the tumors which are less than 2 centimeters. And that are exactly the potentially curable patients. That's why EUS probably should be performed right from the very beginning. Yes, like verifying. Yeah, well, there must be some predictors. You have certain data on patient's history, oncomarkers, and if you want to administer just the usual ultrasound, it will not be informative. And I suppose you come across these diagnoses almost every day. Like, you cannot actually visualize the pancreatic head. And in 86%, it is localized in the head. The cancer is localized in the head. That's why the golden standard, the golden method, MRI or CT. Yes, but it is quite costly, but EUS will be 100% informative. Thank you very much. Just your words should be put into the ears of our health care system reformers, but unfortunately, patients will need to queue up. Yes, Epidemiology wants to say something. Sergey Leonidovich. No. So, for many years you are dealing with this very specific oncology direction. Do you have an impression that there is certain discrepancy between this tumor biology? Because, for instance, finding an adenocarcinoma, and we're talking about this unfavorable adenocarcinoma, which is with a survival rate between 6 to 12 months, that is much more aggressive and malignant than other adenocarcinomas. And it's even more malignant than anaplastic cancers of other localizations. What is your impression? Whether it is a discrepancy, and if it is, then what's the reason for it? I think that it's late detection. Any cancer, if it is not detected at early stage, it will be very aggressive. Then it's very vascularized area, so with metastasis into the liver, and it significantly impacts the metabolic processes. So I don't know, Salavi. Don't know what else to say.
If you are able to stratify patients treatment. That means we are talking about oncological patients who might need surgery directly, who might need chemotherapy and surgery, or who may be too advanced to have surgery. So I think if you have a method that is able to stratify the patients, you spare patients and the society from the cost of surgery that are unnecessary surgery. I think also that we are working on, for example, doing molecular studies on biopsy samples to target chemotherapy. So if you are able to target chemotherapy, that means to establish which chemotherapy the patient will respond the most, you're going to be able to save money because you're going to give that therapy that works the most, and you will not give other therapies that will not work and will cause side effects for the patient. So I think in the future, what is going to happen also is that we are going to have methods to treat lesions that are difficult to assess in another way. For example, the mediastinum. With the EUS, combining the transesophageal and the transtracheal EUS, you can do lung cancer staging of the mediastinum without surgery. That means you basically spare the patient from futile thoracoscopy, and you spare the society from the cost of these things. So I think there's a lot of things that are cost effective. For example, if you have perigastric lymph nodes in a patient who had a tumor before, was operated on, and that one is probably a metastasis, if you can get the diagnosis with a puncture from the stomach, it's going to cost less than open the patient and get the sample by surgery. So I think there are economical saving, even though it's the equipment costs money, the accessory costs money. But I think if you put together, and there are studies out in the literature that shows that there's economical advantage of doing EUS, and I think it will become more and more evident when we are going to be able to do EUS-guided therapy. For example, if you can treat 1.5 centimeter neuroendocrine tumor through some kind of EUS therapy, instead of doing distal pancreasectomy, you will avoid a surgery to the patient, the complication, because distal pancreasectomy has in high volume centers still have a 15% fistula formation and all the hospitalization and stuff like that. So I think you will save money, even though if your perception initially is that it's a costly procedure.
Ну и поскольку вопрос немножко не прозвучал.
And since this question has not been asked, and Alberto was talking about target therapy, we all do know, or we heard about the Carrera cascade, when from normal situation up to the stomach cancer. There is in pancreas there is the same cascade based on the PEN classification, pancreatic intraductal neoplasia, and which shows some changes in acinar epithelium, and at one of the PMN3, I suppose, there appears some mutation of KRAS gene, and if we have this predisposition when KRAS is present, KRAS mutation is present, then KRAS is a method for genetic analysis, and comparing to the CL antigen, CL29 and 241, when it appears as a sort of fourth stage, then KRAS is very sensitive. You can find it in blood with very low concentration at early stages of the disease. So if you diagnose pancreatitis and cancer in pancreas, one of the options is to assess KRAS gene. So if we suspect predisposition, answering your question, it's possible this method will be quite of great help for us.
Thank Thank you very much. Let us thank our presenter.